Thank you very much. It's a pleasure to welcome everyone.
May I start with a bit of personal information? When Noemi contacted me and asked me to speak about scoliosis from the perspective of a physiotherapist, I was very happy to say yes. But as I was preparing for my presentation, I was no longer sure because so many questions. How can I talk about this briefly, generating an interest and maintaining an interest in the issue? Well, in many areas of our lives, we face uncertainties. And I think that is the same in the case of CMT patients. Many questions come our ways, especially if there is an added scoliosis in our diagnosis. Let me share a couple of things with you, a couple of these questions. Could it have been prevented had we noticed it in time? What can I do to prevent scoliosis? Is it enough to exercise, to use the services of a therapist, and so on? So I decided to try and share some ideas about this, and also to bring some joy into the procedure. I think it's very important to create a safe and happy environment for the treatment to take place. So when I started to build my presentation, I decided to break it down into two chapters. In the first one, I will give you some theoretical background, and in the second section, I will tell you about the actual therapy from the initial survey of the patient's condition all the way through to the therapeutic techniques I use, and then finally to how we proceed going forward. Now, this is a sketch of a human spine. You see physiological, that is healthy, curves in the spine. And there are a whole number of aspects from the number of vertebrae, and each section, numbered traditionally, has its own role. Now, these sagittal spinal curves develop in the womb, and as you are born, these curves develop and become physiological, become healthy. And it's important that these curves can become pathological. They might change into a not healthy condition, and that actually ends up influencing all the healthy curves as well. Now, look at the person from the back. You should not be seeing curves, and if you still see curves, then you can talk about scoliosis already. So a definition of a scoliosis is when you talk about a degree more than 10 Cobb degrees from the vertical. This could be a dynamic situation that could deteriorate over time, and the earliest you notice it, the more you can do, but also the earlier it presents itself, the worse the diagnosis and the prognosis will be. It is important to check all the angles of the various anatomical parts of the spine and the vertebrae. On the convex side, you see the joint between the ribs become larger, whereas on the concave side, there is a contraction of the space between the ribs. This also impacts the muscles and the ligaments and tendons. We're talking about scoliosis of 80 to 90 degrees when actually the internal organs might be affected. Now, this is a a grouping of scoliosis prognoses based on their types. You have functional and you have structural scoliosis situations. The difference is that in the case of functional scoliosis, the vertebrae do not rotate out of position. So when you do some screening, you do not see any anatomical changes. Whereas in the structural group of scoliosis situations, you do find those anatomical distortions. And now within that latter group, we have idiopathic and secondary situations. When we understand what the fundamental diagnosis is, and you know that fundamental situation created the scoliosis. In the about 80% of the structural scoliosis situations are idiopathic, and only 20% are secondary to a basic fundamental condition. Now, when you talk about secondary scoliosis situations, that's what includes CMT-based neuromuscular scoliosis conditions. But it is also possible that the individual vertebrae developed incorrectly. Now, a couple of examples from the two largest groups. This is a case of functional scoliosis. Sometimes we know the etiology, sometimes we don't. The most common is when the length of the two extremities is different, and the longer arm, for example, or actually the longer leg creates a tilt in the pelvic area. In this case, you shouldn't be treating scoliosis itself directly. You should be treating the fundamental condition. And this person is a young girl. Of course, I have the approval of the parents to use this photo, the consent. They understood the diagnosis of this young girl, and they already had corrective footwear, which the girl sometimes wore, sometimes didn't. And of course, I had to emphasize that she has to wear those shoes regularly, because on the left image, she's not wearing the shoes, the corrective footwear, and her body becomes all asymmetric. You can see the tilt in the pelvis. You can see the scalpels, the shoulder blades shifting out of position. And on the right photo, you can see her wear her corrective footwear, and her body all of a sudden becomes all symmetrical. I always use manual therapy for the trunk of the person. And every time we apply this treatment, since she's standing up, she needs to be wearing the corrective shoes. Now, another type is the neuromuscular scoliosis, which includes CMT patients. The second example is something to compare with something to be compared with other types of scoliosis. Here, almost every second scoliosis case is down to this cause. And we typically understand what the basic diagnosis is. Sometimes we already do therapy on a child as they are recognized to develop scoliosis. And every single time when we can then give a negative prognosis, we know that it will get worse. Typically, idiopathic scoliosis, once the bone structure matures, we understand that the situation of the person might not deteriorate any longer. However, in this case, in this group, we understand that there will be a deterioration over time, even after maturity. And if the scoliosis is actually mobile, it is important to use a corset-type brace in order to slow down the progression. Idiopathic scoliosis has a system based on degrees of distortion, and wearing a corrective corset could be a partial solution.
A 45-50 fok fölötti görbületek lesznek műtéti indikálva.
And of course, these are situations when we might go as far as having to indicate surgery. Now, let me switch to the second phase of my presentation, the actual therapy process. When I am contacted by the parents, in my practice I work with children typically, I see children who have been sent to my therapy by a physician, or it is the parents who notice that their kids have some problem with holding their feet, their posture, their spine. And the first session is about an extremely detailed anamnesis. I go through their life from the date of birth all the way through to their current age, asking a whole bunch of extremely detailed questions. And only then do I take a look at the child, and I check their abilities either in a seated, a standing, or a supine position, lying on their backs. Now, this girl has a strong hypertonia situation. The body is not distributed, the body weight is not distributed over the two legs in equal proportions. I always try to make sure that they have as little clothing covering their bodies as possible during the examination to see how the body works. I usually measure the length of the extremities. Then I also check them in dynamic situations while moving. She's 4 years old, and her development lags behind her peers of her age group, basically. And once I'm done with that initial survey, then I draft a proposal to the parents about which therapeutic direction we should venture into, what additional specialized medical examinations should be well placed. And I think that the therapeutic plan must be designed in a way that builds on cooperation with the parents and the family, but is also customized to the needs of the child. But the key sentence is it should be something that the family can commit to. It's not a good idea for us just to come up with an idea that the family cannot possibly implement. Now, the previous presenter mentioned the Pfeffenrod therapy. I have some footage of that. This is a thoracolumbar maneuver. And what we're doing with this 5-year-old child, he has a neuromuscular scoliosis situation because of an incident of low oxygen in the brain. And like I said, we always try to rely on active exercises, because after a lot of stretching and loosening, I go into a playful series of movements that will round off the therapy in a pleasant way. I use a whole lot of other specific 3D therapies to work with the spine. Short therapy is extremely complicated, both for the patient and for the therapist. But while complicated, it is also extremely useful. And of course, we need to make sure that the patient is cooperative. If the person has no mental disabilities, then we can start using short therapy from kids age 8 or more, once again, provided they don't have a mental disability. In that case, we have a very specific body posture, and the method uses tactile and verbal stimuli. The child is asked to move their body in specific ways and to breathe in specific ways. And you can also obviously rely on the visual feedback. There is a mirror typically applied for the child to be able to see their own body position and become aware of their posture and movement. And very often we also add breathing exercises. That means bodily exercises combined with breathing techniques. And maybe just a few shots. Going back to the first girl, many of these exercises are quite playful and fun to do together. And of course, together is a key word here. Noemi already mentioned in the morning that I and my colleagues believe cooperation is indeed important. Patients affected by CMT must be provided with a safe therapeutic environment, which is what we work on. And if a child needs to participate in several different types of therapy, then the experts working on the same child should be able to cooperate in order to ensure the efficacy of the therapy applied by each of them. And as a physiotherapist, I like to cooperate not only with the child and the family, but also with the orthopedic physician who sets up the initial diagnosis and then monitors the pathway of the child over time. If we need a corset to support the chest and the spine, I really like to cooperate also with the person, the technician who actually puts together the corset for the patient, customized. And of course, if surgery comes into the picture, I also prefer having a contact with the operating physician, surgeon. And basically, I would like to finish this presentation with a call for cooperation, because from uncertainty, I would like to lead these families to the realm of reliability, and I would like everyone to straighten out the pathways of these kids as much as possible together. Thank you.